It is my great pleasure to introduce Nassar Hanna, who was one of my mentors at Indiana University. He is a worldwide expert on lung cancer. He really is one of the leading authorities in the field. Some of the studies that have defined what we do with patients with lung cancer in the United States and in other countries were done by Dr. Hanna. He is used to speaking to, varying size groups. But at ASCO, our national meeting, he will be talking to thousands of people. He really is a thought leader in the field and also a very thoughtful guy. I mean, he was a great mentor, not just for us medically, but also in how to lead your life and participate in the community, and super thoughtful and smart, and I think you're really going to like his talk. So, Nassar?
Thanks, Eric. Well, thank you, Eric. So first of all, thank you for coming tonight. This is really a pleasure for me to be here, and it's fun for me to see Dr. Bernstein and Dr. Herbert and Jennifer Porter. I feel like this is an Indiana University reunion of sorts. I worked with the three of them, and you are cared for by some tremendously bright and gifted and thoughtful physicians and nurse practitioners. And I was so impressed by the practice that Eric showed me earlier. So thank you again for inviting me. What I'd like to do is kind of talk about how we're thinking about lung cancer today. I've always thought that when we solve the puzzle of metastatic lung cancer, we'll have solved the puzzle of cancer. And I think in many ways that's very true. And the reason why I say that is because everything that has gone abnormal from a normal cell to a cancer cell really can pretty much be found in a lung cancer. And so as we begin to pick apart the puzzle and put the pieces together for lung cancer, we're really understanding many different cancers at the same time. Now, this first slide is a depiction of Edvard Munch's death in the sick room. And this is really the image that people think of when they think of cancer, certainly in the 19th century and even for most of the 20th century. It's a very beautiful but very powerful piece. And as somebody who's been practicing oncology for 15 years, I can tell you that unfortunately there still are a lot of scenes like this. A diagnosis of cancer is oftentimes, not always, but oftentimes the most difficult thing that's happened in someone's life. And it affects their loved ones, it affects their community, it affects their friends, and it does affect the physicians and nurses and healthcare providers that take care of them. And it can take a tremendous toll. And so there's no group of people who are more determined to find better treatments, to find prevention, to provide early detection than those who take care of people who have cancer. So lung cancer cases are going to continue to increase globally for the next decade. Now, thankfully in the United States, those numbers are coming down because the tobacco epidemic in this country peaked in the 1960s and 1970s, and the trends have been down ever since. But globally, lung cancer continues to expand, and that's because parts of South America, Asia, Europe, smoking rates continue to increase. A few years ago, it was estimated that there were 1.6 million people who would be diagnosed with lung cancer. By 2020, it will be over 2 million people. And just to put that in perspective, in the United States, in 1900, there were 200 cases of lung cancer. It was a rare and peculiar diagnosis. If you were to open up an old medical textbook from the 1930s and read about diseases of the lung, you would read volume upon volume about tuberculosis and other infectious disease. And lung cancer was really but a footnote. Lung cancer became a common disease in the 20th century and continues to expand globally and will so for many years to come. The good news is that lung cancer mortality is falling in the United States. And the slide's a little bit blurry, but at the beginning of the 20th century, which is on the far end of the slide there, you can see that lung cancer mortality was similar to that of leukemia and pancreatic cancer, far less than liver cancer, prostate cancer, colon cancer, stomach cancer, certainly far less than breast cancer. But you can see that sharp rise in the incidence of lung cancer mortality. In the 1950s, it started to rise, and it peaked in the 1990s. And lung cancer mortality surpassed breast cancer mortality in women 30 years ago and continue to expand rapidly past it. But the good news is it is starting to come down, and that's, again, largely because of this. That's public policy. The main reason why lung cancer mortality is precipitously falling over the last several decades is not really due to doctors. It's not really due to advances in medicine. It's public policy. And you can see every step of the way, public health heroes who fought to combat the tobacco epidemic made a dramatic effect on the incidence of smoking rates. And the smoking rates continue to go down. The end of the slide there is around the year 2000. In 1964, about 50% of adult men were regular smokers. About 40% of adult women were regular smokers. Smoking was ubiquitous. It would have been in this church most likely. It would have been in your airport, in your restaurant, in your hotel. It would have been in your supermarket, in your Walmart. Of course, today now, it's very hard to find any indoor smoking. And now about 18% of adults are regular smokers in this country. And the reduced tobacco consumption is directly responsible for the precipitous fall. As you can see, the dark curve there is tobacco consumption. You can see about 3 decades after the precipitous rise in tobacco consumption is the precipitous rise in mortality from lung cancer in men. And then you can see about 2 decades later, the lag for female cancer mortality. Women started smoking heavily around the time of World War II. Men started smoking heavily around the time of World War I. So there's about a 2 to 3 decade separation in the rise in those curves. But you can also see as tobacco consumption decreases there, which is the black curve, the male cancer, lung cancer mortality is falling, again, about 2 decades or so afterwards. But we do think it's going to follow that same pattern, and you're going to see that regardless of anything that the doctors do. Tobacco, though, still remains a global genocide. Over a billion people smoke in the world today. 10 million cigarettes are sold every minute. 100,000 kids start smoking cigarettes every day. And we know that smoking is a habit that is initiated by and large in teenagers. If you get to be about 25 years old and you've never smoked, you're going to be a never smoker. 20% of young teens in the world between the ages of 13 and 15 smoke, and half of them will smoke for at least 15 to 20 years. And very difficult to read there, but 500 million people living today will die due to tobacco, and that's the entirety of North America and Central America combined. Another way of stating this is someone dies from tobacco every 8 seconds. As Dr. Bernstein mentioned, it's been one of my passions, and I've worked in my local community to help reduce smoking rates and targeting teenagers in particular. But even if we were to get rid of tobacco across the board, 100% get rid of it, we would still see an epidemic of lung cancer for decades to come. The majority of people who are diagnosed with lung cancer are not active smokers. Only about 35% are active smokers. About 50% are former smokers, and about 15% of people with lung cancer are never smokers. Now that differs based upon gender and parts of the world. For instance, in China, 50% of women with lung cancer are never smokers. In the United States, 20% of women with lung cancer are never smokers. Only about 7% of men with lung cancer in the US are never smokers. Some of that is attributed to secondhand smoke. Some of it is attributed to occupational exposures, dirty workplaces, exposure to asbestos, high exposure to radon, which becomes uranium, a whole host of other things, chemicals and metals and plastics, although a large number of people have lung cancer for unexplained reasons, although we're now beginning to understand that as well. So for this next generation, we must continue to work on better treatment and early detection. So for the vast majority of my career, there was no screening for lung cancer. We tried chest x-rays, several large trials performed in different parts of the country looking to screen high-risk people with chest x-rays failed to reduce mortality from lung cancer. You could certainly diagnose more lung cancer, you could treat more lung cancer, but that doesn't mean that the number of people dying from lung cancer would be fewer. That changed with screening CT scans. The government initiated a $250 million study across the country. 50,000 high-risk individuals participated. These were people 50 and older who had been prior smokers or active smokers or had some other major risk factor for lung cancer. Half of them received an annual chest x-ray. Half of them received this low-dose CT scan. And it turns out, these are the results, the group of people who had the low-dose CT scans, we had more diagnoses of lung cancer, but we knew that would happen because you have a better scan, you find more cancer. But what's more importantly is the bottom part of this slide, and that's that lung cancer mortality rates declined. In other words, 20% fewer people died from lung cancer. So now lung cancer screening programs are popping up all around the country, and CMS, which makes the rules for Medicare, has just announced that they will pay for screening CTs, which means that third-party payers and insurance companies will be paying for them as well. Now, if we think about the diagnosis of lung cancer in the 20th century, it really mirrors that of cancer treatment in the 20th century. Today, surgery remains the best therapy. If you have a localized tumor, you take it out. Today, we can do what's called minimally invasive surgery. So we have our surgeons have these wonderful techniques to reduce the huge incision and the big open thoracotomy that they used to do, and they can now put scopes into the chest and remove entire lobes of lung. Radiation therapy is also a continued mainstay of therapy. If you cannot surgically remove something, but it's localized, you radiate it. And this is 20th century technology, but it's still done today. What's different today now are the radiation techniques. They're better. They use better technology, there's better planning, they spare normal tissues to a much greater extent than they used to do. And then for patients who have advanced disease, we used cancer drugs. And these cancer drugs were nonspecific. They nonspecifically kill cells, and they were largely discovered by serendipity. There was no grand plan to find most of these cancer drugs. Some of them were found by accident in plants. Some of them were found somewhat by observation in laboratories. Probably one of the most interesting discoveries was platinum, a metal. Platinum is an incredibly active cancer drug. It's used against a dozen different cancers. But it was discovered as a cancer drug by complete accident. A bioscientist at Michigan State University set up an experiment in his laboratory to see what the effects of an electrical current would be on a bacterial cell. And the observations that this scientist reported could not be attributed entirely by that electrical field. He set up a water basin, put E. coli in the water basin, put 2 electrodes, sent an electrical current through the 2 electrodes. It turns out that the kill of the cells was due to the platinum metal on the electrodes. Again, just a discovery by accident. And really, for most of the 20th century, this is how we attacked most cancer. You cut it out, you radiate it, or you poison it with drugs that were discovered mostly by accident that kill cells in a nonspecific way, and oftentimes are associated with a tremendous amount of side effects to the patient. And that's because we continue to have a poor understanding of what cancer is, what the molecular basis of the disease is. During the 20th century, this began to change, and we began to have a very basic understanding of cancer biology. We discovered a plethora of genetic abnormalities. We didn't really understand what they meant, what was important and what wasn't important, but just an observation that a certain gene was abnormal here or a certain gene was abnormal there. We labeled these oncogenes, or tumor suppressor genes, based upon the function of the gene, and we gave them names, and we decided we would label some of them as targets of cancer drugs, and the very earliest cancer drugs, targeted cancer drugs, began to emerge in the last couple of decades. So a very, very basic understanding of the genetics of cancer. Well, what's really heralded tremendous amount of understanding and advances in cancer is what we call the genomic era. So about 15 years ago, scientists from the US government, but also a French group, simultaneously mapped the human genome. And this was the beginning of understanding what genes are normal, and then we would further discover what is abnormal. So first you have to know what's normal to really know what's abnormal. Well, what we discovered is that the human genome is comprised of about 25,000 genes. It cost $1 billion to do this, and it took many, many years. And what's good is that only about 4% of our genes play a role in cancer. So the pool of things that are abnormal is not this huge array of genes. It's actually a handful of genes, and there are common themes. The genes that are abnormal in melanoma can be found in lung cancer. That gene that drives the growth of breast cancer in a patient can drive the growth of lung cancer in another patient. And so this is the type of understanding that took place over the last 15 years. Now, the challenge with lung cancer and what distinguishes it from other cancers, and the reason why I said when we understand lung cancer, we will understand cancer, is partly explained by this slide. So one of the things that happens in cancer that's quite abnormal is when a part of a chromosome that carries a lot of genes breaks off and gets transposed someplace where it doesn't belong, to another chromosome. And this is a theme in cancer. So you get genes that are in a neighborhood they're not supposed to be in. Well, when they're in the wrong neighborhood, sometimes they act badly. There are some cancers for which one of these genes acts badly. A good example of this is a disease called CML, or chronic myelogenous leukemia. And in this disease, there literally is one chromosomal translocation that brings 2 genes next to each other that should not be next to each other, that then causes a function to happen to give you the leukemia. Well, we have a great treatment for chronic myelogenous leukemia. It's a pill that you take once a day and puts the vast majority of people with this leukemia into a complete remission. In lung cancer, it's not that easy. This is one cell line in lung cancer. This person doesn't have one chromosomal abnormality. This person has dozens of chromosomal abnormalities. There is so much genetic injury that has taken place. Lung cancer is considered to be a very genetically dirty disease. There are so many things that have gone awry. It's one of the reasons why it's observed to be a cancer, usually in older individuals. The median age for lung cancer is 70, and that's because it takes a lifetime, decades and decades, for these genetic abnormalities to occur and accumulate one on top of another on top of another. It's actually kind of hard to get lung cancer. It takes a lot of genetic changes, and another slide will underscore that. This is a tumor in a single patient who has adenocarcinoma of the lung. This person's tumor, their entire genome, every gene in this person's cancer was studied. This is a 51-year-old male who was a smoker. And the genome of those cancer cells were compared to normal adjacent tissue that does not have the cancer. What they found was that there were over 50,000 errors. In other words, there were over 50,000 genes that had an error here or there, that there was something that was different than the normal adjacent tissue. There were at least 8 of what we call these cancer pathways that were altered. Not one pathway, but at least 8 of these cancer pathways. And remember I told you chronic myelogenous leukemia has 1 chromosomal rearrangement? This patient's tumor had 43. That's how complicated this is. Now, tobacco is the primary culprit for lung cancer. And tobacco induces a huge mutational load. So using the prior patient as an example, that 51-year-old smoker I just showed you, that patient had lung cancer develop after 50 pack years. So a pack year is how many packs per day times years. So a pack a day for 50 years is 50 pack years. 2 packs per day for 25 years is also 50 pack years. So a pack year is 7,300 cigarettes. The clone of cells that ultimately become cancerous would require, over its lifetime, an average of 1 mutation for every 15 cigarettes smoked. That's actually very conservative. Some people estimate that you get a unique genetic mutation for every 3 cigarettes you smoke. So if you have 20 cigarettes in a pack, and you use that aggressive assumption, that means you develop 7 mutations that you did not have before you smoked that single pack of cigarettes. It's really quite stunning. A more conservative estimate would be a new genetic mutation for every 15 cigarettes that are smoked. So about 1 per pack, or maybe 3 per 4 packs. Or 4 per 3 packs, sorry. Okay, so that's what we're dealing with. That's the level of complexity that we're dealing with. Well, this is what Dr. Bernstein and Dr. Herbert and Jennifer Porter did for the first part of their career. Patients usually present with metastatic disease. It's different than breast cancer. It's different than prostate cancer. Most people with breast cancer, not all, but most, are diagnosed with a very early stage tumor. That's because you can feel a lump or detect it on a mammogram. Most men with prostate cancer are detected early. Their PSA goes up, or they have some urinary symptom that causes them to get an exam. Not true for lung cancer. 2/3 of people who are diagnosed with lung cancer have already developed metastatic disease by the time they're diagnosed. And when they're diagnosed with metastatic disease, what was done for the good part of 30 years was to give them combination chemotherapy in a very empiric way. You take drugs that work synergistically together, that patients can tolerate, and you give it to them. And what was observed on this survival curve is the patients who received chemotherapy, which is CT, did a little bit better than SC, which is supportive care. Supportive care would mean oxygen and morphine and something for anxiety and nursing support and psychological support and so forth. So you could see a very modest improvement in how long people lived. Most people would live a few extra months compared to those people who did not receive any therapy alone. We then took the next step to see if there was a combination of drugs that was just a little bit better than another combination of drugs. And this slide summarizes many studies. The bottom line was it didn't seem to matter. We had about half a dozen drugs. You could give them in all different combinations and dosages and lengths and duration and schedules, et cetera, et cetera. And at the end of the day, those survival curves were really pretty overlapping. So the mantra was combination chemotherapy with 2 drugs. You give it for 4 to 6 cycles, and that's what we could offer patients. And it led to a modest gain for some patients. Now, granted, there were a handful of patients who would get a tremendous amount of gain from this, but that was a very small percentage of people. The next advancement was with a drug called Bevacizumab. So again, one of the themes in cancer is if you can't kill the cancer cell, maybe you can disrupt its supportive network. And what does cancer need? It needs blood. It needs blood to deliver oxygen and nutrients. Without that, cells die. Doesn't matter if it's a cancer cell or a normal cell. So a strategy then was to develop drugs that disrupted blood vessels. And this is being done in a whole host of different cancers. Bevacizumab is one of those drugs that interferes with those blood vessels. So it was tested in lung cancer. And essentially, this was the clinical trial. To summarize what this trial was, we took patients with advanced lung cancer and we randomly gave them either chemotherapy or chemotherapy plus this new drug, Bevacizumab, which was, again, a drug that disrupted the blood vessels. And it turns out that it was a little bit better. Not a lot better, but a little bit better. So we claimed a small advance, and the standard of care changed so that patients were receiving combination chemotherapy with a third drug, which was not a direct cancer killer, but rather a drug that interfered with blood vessels. The next advance came with understanding that not all lung cancer is the same. Now, you would think we would have figured that out, but if you notice, the title of my talk was non-small cell. So we're defining a cancer by what it is not. That term is derived from the 1960s. And in the 1950s and up until that time, patients with lung cancer were all treated the same. Surgery, the same chemo, the same radiation. And then it was observed that there was this group of patients with this type called small cell that behaved a little differently. So they should be treated a little differently. So then everything else was called non-small cell. Didn't matter what the subtype was, we just kind of all lumped it together. So the landmark trials for patients who have metastatic lung cancer that established our standard of care, and I listed a bunch of trials up here with a bunch of comments, but really what this slide says is that we did not consider the differences in what actual subtype of lung cancer a person had. Well, that was clearly wrong because we must consider the subtype, the histology. And this gives you an example of why, and I've listed a couple of the 2 main non-small cell subtypes, adenocarcinoma and squamous cell, and for reasons of safety or effectiveness, some drugs work better than others. So that was a small but important advance to recognize that we can't call things non-small cell anymore, that we have to refer to them by their histology. The next advance, which was very modest in the 20th century, was an idea of maintenance therapy. Now, if I take you back to the 1950s, maintenance therapy was given to everyone. And the reason why is because it was thought that if you stop treating patients with these drugs, that the cancer will quickly reconstitute itself and the patients will die more quickly. And despite the fact that there was only one disease for 50 years in which that proved to be true, and that was childhood acute leukemia, that strategy was employed in just about every disease. Well, we came to our senses in lung cancer in the 1990s and stopped doing that because the drugs we had were not terribly effective to begin with, and they were pretty toxic. So we started to give patients less and less therapy. Well, what happened at the end of the 20th century is we started to develop a little better chemotherapy, so a little bit more effective and less toxic. So we revisited this question of giving maintenance therapy for a very long time. And really, this slide summarizes maintenance therapy. I won't go through the details, but I would just have you look at the last column there, which is overall survival in terms of months. And in the 1980s and 1990s, with combination chemo for 4 to 6 cycles, it was generally about 8 or 9 months. And those are the kind of results we get with modern chemotherapy, with the anti-vascular drug, anti-angiogenic drug, and with maintenance therapy. So that really summarizes the 20th century advances. Better chemotherapy, maintenance chemotherapy, anti-vascular drugs. We moved the bar very modestly. And this is how I've spent most of my career, trying to fine-tune not so good therapy. We did develop a series of drugs that we could give after patients had had growth of their cancer after our first effort against the disease. This is so-called second-line therapy, and I'm going to get a little bit more into this with the next slides. So what's changed? What's changed is our molecular understanding of cancer. You cannot solve a puzzle unless you have the pieces to the puzzle. It turns out that for some patients, while they may harbor lots and lots of mutations, and by the way, everybody here, including me, has an imperfect genome. In fact, if we do a swab of our buccal mucosa, look at those cells, and sequence every gene we have, and then do it again next month, we will be less perfect next month than we are today. And if we do it 5 years from now, we're going to be much less perfect than we are. We have mutations that are occurring all the time. We repair some of them, and we live with some of them. And the reason why we do okay is because, remember, out of those tens of thousands of genes, only a handful are critically important for things like cancer. So we get a lot of mutations in genes that really don't have an important function. Well, despite having all these imperfections, there are subsets of patients who have a unique driver of their cancer. In other words, it's not the only mutation they have that caused them to have lung cancer, but it's a key one. And this slide talks about that. 22% of patients with adenocarcinoma of the lung have what's called a KRAS mutation. That was the first oncogene discovered 30 years ago. 17% have a genetic injury in something called EGFR, and that in lung cancer was our first actionable target. KRAS we've been trying to target for 30 years and correct it. We have failed so far. EGFR, we have succeeded, and we'll talk about that. EML4 ALK occurs in 7%, and that's our second target in lung cancer. and we now have therapies that effectively target tumors that have that mutation as well. So let's start with EGFR. If you take a mouse and that mouse's lungs do not have lung cancer, and you alter in a mouse the EGFR gene, and you mutate it, and you keep it turned on, that mouse's lungs, within days, will develop thousands of little cancers. If you give that same mouse a drug that shuts that gene down, those cancers disappear. If only we were as simple genetically as mice, we would have cured cancer a long time ago. But it's still a very important observation. So in human beings that have a mutation in that gene, they have been studied and given a drug that targets that gene, and we've compared their outcomes to patients who are given chemotherapy, who also have that altered gene. And what this slide does is it summarizes all of those studies, and I'll tell you what it says. It says that we're about twice as effective at treating with the single drug that targets the gene than giving these patients chemotherapy. So today, if you have an EGFR mutation and you're diagnosed, you're given one of two oral therapies. You're not given chemotherapy, at least initially. Now, it was observed that these drugs work wonderfully well, but after a while, they stop working. And you think, well, why is that? We know why their cancer is growing. We know this gene is altered. We've given a drug that interferes with that. Why doesn't it just work forever? The way to study that is not terribly complicated. You take a repeat biopsy of a tumor that's growing and resisting your drug, and you re-study the gene, and you see if something has changed. And it turns out that about 80% of the time, we can figure out now why that drug is no longer working. Half of the time, it's because that gene's target has altered very slightly, just real slightly. It's a new mutation in about the same region, and it's altered it very slightly. Well, it's good news to understand that, because all you need is a good chemist. You don't need a doctor. You need a good medicinal chemist. And what that medicinal chemist will do is they'll take your drug and they'll alter it to get into the little pocket where that target has changed. And that's what the big pharmaceutical companies have done. They've made drugs. They're chemists. It's a chemistry problem. And now they have drugs that are incredibly active in these patients who've acquired this resistance mutation. And these are the next generation EGFR inhibitors. There are several of them. Two of the ones that are furthest ahead are one from a small company called Clovis and another one from a large company called AstraZeneca, but there are several others. These are the two that are furthest along. And these drugs were engineered. It was intentional to make these drugs in this way. They target not only the mutated EGFR, but they target that key resistance mutation. And you know, the company said, while you're at it, can you make the drug easier on patients? The two main side effects of this class of drugs is a rash and diarrhea. And the reason why is because that same growth receptor is important for skin development and GI development. So if you inhibit it, you get a rash and you get diarrhea. So the companies told these chemists, look, can you somehow just make it cancer specific? Can you spare the normal, or what we call wild type version of this gene? And they said, sure, that's a chemistry problem. And they did. And so these new generation drugs don't have much of the rash or diarrhea that the first generation drugs do. And these are very, very active drugs, and I'm confident that these are going to get approved by the FDA in a short period of time. The second important target is that ALK. Now I want to spend just a second telling you about ALK and just showing you how rapidly medicine is changing. ALK was named after a form of lymphoma. ALK stands for anaplastic lymphoma kinase. This was discovered like in 1993 in this rare form of lymphoma. So the discoverers named it after the tumor type they discovered it in. Well, it was about 15 years later that scientists from Japan discovered the same gene was altered in some people with lung cancer. And oh, by the way, some people with tumors of muscle, and some people with tumors of the nervous system, et cetera, et cetera. It was not unique to lymphoma. And so had it been discovered in lung cancer, this may have been ALK, maybe an anaplastic lung kinase, perhaps. But it was discovered to be altered in about 7% of patients. This drug, CRizotinib, targets the abnormal ALK. These patients are not given chemotherapy. These patients are given an oral medicine that's designed by chemists. And it turns out that if you have this ALK gene rearrangement, almost 2/3 of the time, your tumor shrinks substantially. And for some people, this effect can last years. Not for everyone, but for some people. So, based upon our experience with EGFR, what do you do to figure out if somebody who's responding to the drug and is no longer responding, why is that? Well, what you do is you rebiopsy a tumor that's growing and restudy the gene and see what's different. And we've done that. And now we have the second generation ALK inhibitors out on the market, and the third generation drugs are coming shortly behind. Crizotinib was the first generation drug. This drug was compared to chemotherapy in patients, just like those EGFR studies were. And this was the difference in how well people did. The oral drug versus chemotherapy in this subset group. This is the duration of time it takes tumors to grow. The top curve is the oral targeted drug. CRizotinib is the second generation ALK inhibitor. It has the capacity to overcome the resistance mechanisms that the tumor acquired when the patients were on crizotinib. And you can see in the patients with non-small cell lung cancer, previously treated with a prior ALK inhibitor, the overall response rate was 54%. In lung cancer, this is really pretty striking and stunning because in this population of patients, we expect response rates with chemotherapy to be about 10%. But an oral drug that was designed by a company can get tumors to respond at least half the time. Okay, I want to conclude the talk today to talk about the immune system. Did anybody see the PBS special, the Cancer, the Emperor of All Maladies? It's really good. Did you read the book as well? The book is really good too. Now, I want to tell you something that differs between the book and the series. And so I'd encourage you, if you've seen the series, read the book, and if you've read the book, watch the series. And that's because the emphasis on immunotherapy is substantially more in the series. The book talks about it a little bit. The reason why is because the book was published about 3 years ago, and the field of immunotherapy is just now exploding. The basic concept is easy. Trust me, there's nothing easy about the immune system. But the basic idea I think we can all relate to. And that is that cancer is recognized by your immune system as foreign, just like it recognizes viruses and bacteria and fungus. That observation we've known for 50 years. But what to do about it has been the trick. So the immune system has evolved over millions of years to detect and eliminate something that is not you, something that is foreign. It's very specific, it's very sensitive, and it can change with simple amino acid changes. If you get the flu shot every year, this year's was a real stinker, by the way. My wife got the flu. I think I did too. We both got the flu shot. But the flu shot changes every year, and that's because the virus is not exactly the same every year. Very simple alterations, and the immune system will detect it as if it were something it had never seen before. It's highly regulated, and it can adapt. That sounds like a pretty good protective mechanism. And let me tell you, man cannot do something like that. That is something that is in us. In other words, we cannot generate something like that. There's nothing better than what your human body does on its own. Well, why target it in lung cancer? Well, in summary, there is a strange advantage to being so foreign. Remember, I told you that lung cancer is the result of thousands of mutations and chromosomal gene rearrangements and altered cancer pathways. Ordinarily, that's why it's so hard to treat. That's been the devil. But for the immune system, it likes that. It likes the fact that it is so foreign. It is so abnormal. So lung cancer is one of the cancers that's leading the field in immunotherapy, along with other very complicated cancers like kidney cancer, which doesn't respond to chemotherapy, melanoma, which really modestly responds to chemo and doesn't respond much to radiation, tumors like bladder cancer, mesothelioma, esophageal cancer. These are cancers that have high mutational loads that are incredibly complex and abnormal, for which there have been frustratingly few advances. Those diseases, you see striking responses with immunotherapy. So lung cancer, ironically, makes for a good specimen for immunotherapy. Now, this is kind of interesting, and I actually referenced this for some of my patients. So decades ago, it was observed if you had lung cancer surgery, and that surgery was complicated by a serious lung infection, you had lower recurrence rates of your cancer. Isn't that strange? And it's thought because you had a huge immune response, unintended, that went to the lung and probably killed microscopic cancer. So this was a publication from decades ago. This is in 1972. Patients with lung cancer who developed an empyema, which was basically a pus, it's an abscess just outside the lung, they had higher 5-year survival rates, 50% versus 18% if they didn't have that. Now, I'm not telling you to have your surgeon intentionally give you an infection, but it is an interesting observation and should clue us in that there's a reason for this. So we've tried immunotherapy in lung cancer. These are a handful of lung cancer treatments that have really not been terribly effective. But that's not because the immune system's not important, it's because these therapies were not that effective. So I'm going to conclude my talk with telling you about the most interesting and maybe exciting advance in lung cancer during my career that I think will have a broad effect on a lot of patients. And that is this concept of cancer immunotherapy with a target called PD-1. And the concept is very simple. Now, you guys don't have a professional football team, but you do have college football. So does anybody watch football? Okay, pretty simple concept. This is how I explain it to my patients. Trust me, it's way more complicated than this, but I'm not that smart, and this is how I think about it. I think about the cancer cell as being a running back with a football. And that cancer cell is running down the sidelines towards the end zone. And running after that running back, that cancer cell, is a defensive guy who's sprinting after him, and he catches up to him. And what does the running back do to prevent the defensive guy from tackling him? He stiff arms him, right? Puts out the stiff arm like that so he can't get near him. Well, that's essentially what cancer does to your immune system. So there's a cell called a T cell, which helps fight viruses. It helps fight fungal infections. And by the way, if you're depleted in T cells, you're susceptible to cancer. This is why people with HIV get cancer. This is why patients who got organ transplants, who are on drugs to prevent rejection of those transplanted organs, that's why they have higher incidence of cancer, because the drugs that they get to prevent the organ rejection suppress T cells. Well, there are a new class of drugs now which basically break the stiff arm. The running back with the football is the cancer cell, and he has on his surface something called PD-L1. And the T cell, which is your immune cell, trying to kill that cancer, is that defensive guy trying to get near him. He has on his surface something called PD-1. And when PD-L1 and PD-1 mix it up together, they can't get close to each other. So now the pharmaceutical companies and governments understand this, and there are drugs that block PD-L1 on the cancer or block PD-1 on the T cell. So what is really cool about these therapies, these PD-1 and PD-L1 inhibitors, is that they don't kill cancer. What they do is they allow you to kill your own cancer. It allows your immune system to do what it wants to do in the first place. Well, it's all kind of cool. Does it really work? Well, people who have melanoma, people who have kidney cancer know it works because they've been getting these types of therapies now for a little while. There's actually a very old drug that's 40 years old that depletes T cells that have cured people with metastatic melanoma decades and decades ago. So in lung cancer, we finally have our first drug, and that is Nevala Mab. Nevala Mab is a PD-1 inhibitor. And in people with one of the dirtiest, most genetically abnormal cancers, squamous cell cancer, were given this drug. They were compared to those with chemotherapy. And the top curve is immunotherapy, and the bottom curve is chemotherapy, and that's a survival curve, and it shows you the difference favoring immunotherapy. Now, the real neat thing about this is in this past issue of the New England Journal of Medicine was a publication on the long-term experience in melanoma with the same drug. And they wanted to know if anybody was being cured. These are all patients with metastatic melanoma considered incurable, given this class of drugs. And because they were ahead of the curve in studying this years before we were in lung cancer, we now have information on how those patients are doing 5 years plus later. And it turns out that about 20% of those patients with metastatic melanoma who were given this drug 5 years ago are still alive without any cancer growth. Does that mean they're cured? Some might be, some might not be. But that's really kind of the definition of turning cancer into a chronic disease. Now, is that going to happen in lung cancer? My experience tells us not to be expecting that, but that curve does seem to start to flatten out at around 18 months. We'll see. We'll see what happens 3, 4, and 5 years from now if that remains the same. So I started the talk off with Edvard Munch's depiction of death in the sick room, and I'll conclude with the same artist's rendition of the Dance of Life. And truthfully, this is why we are oncologists. Not because we're obsessed with death, but because we're obsessed with life. And we love life, and we want to see other people can live long and happy lives. So thank you for your attention. Thanks. Yeah, great question. Why do you think there seems to be an increase in lung cancer in women who have never smoked? Honestly, we don't know the answer to that. We know that there's a higher incidence of EGFR mutations. A small amount of this is related to secondhand smoke. We know that there are some differences in the interplay between estrogen receptors and some of these other growth receptors that can lead to cancer. We also know that, that there are differences between the sexes in how we metabolize carcinogens. The short answer is we don't know. There are some hypotheses, but we really don't know. Okay. So what screening schedule do you follow for high-risk individuals? The recommendation is annual. The study was for at least 3 years, but the guidelines seem to be you can continue them to do annually. There's no end point to them. But really, for most screening studies, we look at whether somebody's life expectancy is at least 5 years, if not 10 years. If somebody's life expectancy for other reasons is less than 5 years, it's probably not wise to continue to screen them to find them a problem that they really aren't going to be affected by. So probably at least 5 years, but some people would say indefinitely as long as they remain in good health. Why more than double rate of women versus men die from cancer? Are women exposed to worse working environments? I think it's harder to be a woman in general. I'm just kidding. Actually, I think it is. My wife will tell you that. I've got 2 daughters, so it's harder to raise daughters than sons, I think. Actually, the death rates from cancer amongst men and women are about the same. Women, there were fewer cases in women for years and years. Women caught up to men about a decade ago. It's really very, very sad. But women do live longer with lung cancer than men. Their prognosis is a little bit better. Do we really understand how smoking induces mutations? Yes, we definitely do. So there are at least 60 carcinogens in tobacco smoke. At least a dozen are proven to be human carcinogens. These are cancer-causing substances. The 2 major classes are benzopyrene and nitrosamines, and they cause significant damage to DNA. They cause kinks, they cause alterations in the DNA, and lead to widespread mutation. So we do understand how smoking induces cancer. How many translocations for AML? That differs. Some AML, so it's not one size fits all, and I am not an AML expert, but that is variable. Is IL-2 immune therapy? Yes, it is. IL-2 is a T cell modulator. It manipulates T cells just like, it enhances the effect of T cells. That's why the side effects of IL-2 are similar to the side effects of these other immunotherapy. It augments the T cell effect against cancer, but also against you. So it can give you what we call autoimmune diseases. It can give you inflammation of your colon, of your liver, of your kidneys, of your skin, of your joints. It can give you fevers and rashes. So interleukin-2 does this. It's the worst. It's much harsher than the immunotherapy that we have today. Pot smoking. Does it cause cancer? Now, is pot legal in New Mexico? Not yet. What's that? Medical marijuana. It's legal? Wow. Indiana will be the last state to legalize marijuana. By the way, Indiana is a great state. I think it's a dose effect. So when people smoke cigarettes, they usually smoke a pack or 2 packs a day, which is 20 to 40 cigarettes a day for decades and decades and decades. Pot has many carcinogens as well. It's just that most people don't smoke 20 to 40 a day, every day, decade after decade after decade. There's nothing more political than the use of pot to kill cancer. And that's because there are some animal studies that show if you knock out the receptors that pot targets, you can kill cancer in the laboratory. But you can do that with lots and lots of things. But I get more questions about pot because I think it's more of a political issue. Mushrooms and polysaccharides are not my expertise, so I don't know the answer to this. But I do get a lot of questions about complementary medicine. You know, I don't have all the answers. I'm always interested in what we call evidence-based care. So if there's good scientific evidence for it that's been studied, and the evidence meets the criteria that we accept in the medical community, I'm all good with that. Was that last day, oh my, what's that? Was that last day, oh, well, sorry, was that last drug mentioned the one you just terminated at 5? Yes, yes it is. Nevala Mab. Nivolumab. There's another drug called pembrolizumab, Pembrolizumab. To me, it's Coke and Pepsi. I think they're essentially the same drug. They're both approved in melanoma. They're both very active in many cancers, including lung cancer. They both target PD-1. How many mutations in lung cancer occur after it has become cancer? Great question. So cancer changes over time. The mutational load continually increases. So cancer becomes more and more complex over time. In addition, when you treat somebody with chemotherapy or any of these other drugs, and then it grows, what you're left with is tougher cancer. These are cells that have adaptive mechanisms, that have other resistance mechanisms, and so absolutely, there's not a certain number of mutations, but we do know because we've studied cancer over time in the same individual. The other thing that's very tricky is that when somebody has early stage cancer and the tumor is studied, and then they eventually develop metastatic disease, the metastatic disease is genetically more complex than the original tumor. What's even trickier is in the same patient, if you study the genetics of a metastasis to the liver and a metastasis to the adrenal gland, they may not be genetically the same. And then if you want to make it even more complex, if you take a single tumor and you study the different genetics in the different cells in different parts of the same tumor, they will not all be the same either. Cancer is a very difficult disease to treat because it is a very complex disease. And really, that's why I like to focus on prevention. That's why my efforts have been on tobacco prevention. For smokers who smoke 20-pack years, what percentage will get cancer? Okay. So I can tell you that about 1 in 7 smokers gets lung cancer. About 30 to 35% of smokers get a smoking-related cancer. The good news is that drops off substantially when you quit smoking. So this study comes from British physicians who smoked, and physicians during the 50s, 60s, and 70s smoked at the same rates as the general population. Same with nurses. In fact, I think they even smoked at higher rates. Jennifer's nodding her head, yes. My dad, who passed away recently, was a physician, lifelong smoker. The good news is if you quit smoking, your rates of cancer do come down and almost immediately. So if you are 50 years old and you continue to smoke, by the time you're 70, there's about a 20% chance you'll get lung cancer. If you quit at the age of 50, after having smoked for decades, by the time you reach 70, there's only a 6% chance you'll get lung cancer. So the rates of cancer do fall substantially, even if you've smoked for many decades at a time. So it's never too late to quit. How often should a high-risk patient get a low-dose CT? Yearly is the recommendation. What role does cannabis play in fighting and curing cancer? So cannabis is an appetite stimulant. It's approved by the FDA to treat people who have anorexia related to AIDS, and it is commonly used in patients who have cancer. In terms of an anti-cancer drug itself, it's not approved for any of that. There is laboratory data on it, but there's no human data that it helps people live any longer. But I hear they feel better sometimes. So do PD-1 I've never smoked marijuana, by the way. Who smoked marijuana? No, I'm just kidding. Who currently smokes marijuana? What's that? Okay. So do PD-1 inhibitors still work regardless of mutation in the cancer cells? Why does the graph flatten out? Yes. So that's the beauty. It doesn't care. It doesn't care why you got the cancer. It doesn't care if it's a KRAS mutation or BRAF mutation. It doesn't care. In fact, the more ugly and mutated it is, potentially the better advantage it has. Why does it flatten out over time? Well, because there are some people, for reasons we still don't understand, who not only respond, but respond for years. And it's because once you give these immunotherapies, it's different than when you give chemotherapy. When you give chemotherapy, there is a brief effect. You have high levels of the drug does its thing, and then it goes away. You either metabolize it, you pee it out, you pass it in your stool. Immunotherapy alters your immune system forever. It's forever different, and it's adaptive as well. So you have altered the immune system in a way that's very important, and in some people it has a long-lasting effect. I wish it was everyone, and I think we'll understand why it works better in some people than others, but we don't know that yet. When a person has cancer that metastasizes to the lungs, is that different than lung cancer? Yes. The biology of that disease is driven by where the cancer originated. So if it originated in the skin and metastasized to the lungs, it's still treated as the skin cancer. And lastly, who should get CT screening? We talked about that. Generally high risk, so 50 and older. We generally refer to 30-pack year smoking. Other people who have worked around asbestos, coal miners, factory workers, or people who have had heavy secondhand exposure, so a spouse of a lifelong smoker, for instance, I think would all fit into the high-risk group. Metastatic breast cancer into the lungs of a non-aggressive type, treated with hormone blockers, Faslodex. Question, do you have any response with this type of lung involvement? Okay, so it's not the fact that it's in the lungs, so that would still be treated as breast cancer. Interestingly enough, though, the estrogen receptor does play a role in other cancers other than breast cancer. For instance, it's a manipulated target in endometrial cancer. We know that if we alter the hormonal milieu of a patient over a lifetime, you can affect their rates of ovarian cancer. And estrogen receptors are overexpressed in many cancers, including lung cancer, and it has been a target in lung cancer, although with mixed results. It doesn't seem to be as critical in lung cancer as it is, for instance, in breast cancer. I think that's it.
I think this is working. Thanks, that was fantastic. Really appreciate it.